Hope you guys can hear me all okay. And on Teams, can everybody hear? I'm not sure if anybody's on Teams right now. All right, I'm going to assume you guys can hear. If you can't, please speak up. All right, so today I want to talk to you about something dangerous. I want you to imagine your next civic recess shift. You just sat down to chart on your last trauma patient, and the nurse grabs you and says, "Doctor, we need you in here." You walk in the room, and this is the patient that you see sitting before you in the stretcher. He's a 62-year-old guy with a muffled voice. He tells you that this morning, after waking up, his tongue started to feel big. There were no exposures to allergen. He's got no known allergies. His past medical history is significant only for hypertension, and he's been on Ramipril for the past 2 years. I want you to take a minute right now and just think about all the things that you've learned about during your medical education about the management of ACE inhibitor angioedema in the emergency department. What treatment options will work, which ones are safe, and which ones are there evidence-based. My name is Nathaniel Murray. I'm one of the fourth-year emergency medicine residents here in Ottawa, and for the next hour, I want to talk to you about the latest evidence in the management of ACE inhibitor angioedema in the emergency department. My supervisor is Dr. Christian Yadav. We're going to take a deep dive in the latest evidence in the pathophysiology, the differential, the treatment options, as well as airway management in ACE inhibitor angioedema. My hope is that at the end of this talk, you will feel more comfortable with an evidence-based approach to the treatment of your next patient. So we'll get started. So what is angioedema? If you look at the literature, angioedema is defined as a non-pitting swelling of the subcutaneous or submucosal tissue of the skin, oropharynx, upper respiratory tract, and GI tract. To the emergency provider, this is our definition of what we think about when we think about angioedema. Angioedema in the body occurs through two main mechanisms. It can either be mast cell mediated or bradykinin mediated. In mast cell mediated angioedema, after initial contact, a person is sensitized to an allergen. On the next exposure, an IgE degranulation of mast cells occur, releasing histamine. This release of histamine causes a cascade which causes leaky vascular endothelium, leading to angioedema. In bradykinin-mediated angioedema, or ACE inhibitor angioedema, we know that it's a truly bradykinin-mediated process. It depends on the kinin-kilokrin system. Essentially, factor 12A is used to convert pre-kilokrin into kilokrin, and then kilokrin is then used to convert kinogen into bradykinin. Bradykinin then stimulates the B2 receptors on the endothelium, causing leaky endothelium and leading to angioedema. Bradykinin is broken down into its inactive metabolites by the angiotensin-converting enzyme. This is where ACE inhibitors act, by inhibiting angiotensin-converting enzyme. C1 esterase inhibitor is the regulatory protein of the system and acts to suppress the kinin-kilokrin system and suppress bradykinin production. While we're talking about ACE inhibitor angioedema today, I want you to be aware that there are other drugs that can cause bradykinin-mediated angioedema. The first one is TPA, that does this truly on its own, and it does this through a plasmin-mediated release of bradykinin. Neprilysin inhibitors, which are a component of our new ARNI drugs, also do this by inhibiting neprilysin, which is involved in the breakdown of bradykinin. In fact, patients who are previously have ACE inhibitor angioedema should never be on a neprilysin drug. Similarly, DPP inhibitors such as gliptins in combination with ACE inhibitors increase the risk of angioedema through the inhibition of bradykinin degradation. So why do we care so much about ACE inhibitor angioedema? Why are we talking about this today? Well, we know that ACE inhibitors are by far one of the most common prescribed medications and by far the most common antihypertensive drugs prescribed in Canada. We know that 30% of all angioedema patients that you see as emergency providers will be secondary to ACE inhibitors. A meta-analysis showed that 0.7% of patients started on ACE inhibitor would develop angioedema within the first 5 years of use. We don't know why some people get it and some people don't, but we know that it can happen hours to years after initiation. 10% of all angioedema cases on patients who are taking ACE inhibitors happen within the first 10 months. Although historically, angioedema secondary to ARBs was thought to be a thing, recent meta-analysis show that the rates of angioedema with ARBs is equivalent to that of placebo. So let's talk a little bit about the classification of angioedema. Angioedema can be classified as hereditary or acquired. Hereditary angioedema is bradykinin mediated and is secondary to C1 esterase inhibitor deficiency. This is your classic sort of C1 esterase hereditary angioedema. We will not be discussing this as there's protocols on how to sort of replace C1 esterase. In acquired angioedema, it can be either bradykinin mediated or mast cell mediated. Mast cell mediated angioedema is your classic allergy or mast cell activation disorders and is along the spectrum in which anaphylaxis lives. In bradykinin mediated angioedema, there's sort of three main causes. It can be either secondary to drugs, idiopathic, or secondary to acquired C1 esterase inhibitor deficiency. The two main drugs that cause angioedema are ACE inhibitors and TPA, and ACE inhibitors are by far the most common drugs that will cause your bradykinin non-allergic angioedema. It's important when looking at this patient in front of you at the bedside on your civic recess shift to not only think about your mast cell mediated disorders and your bradykinin mediated disorders, but also think about your non-mast cell mediated and non-bradykinin mediated disorders, such as contact dermatitis, infections, facial lymphedema, autoimmune edema, such as SLE, hypothyroidism, and SVC syndrome. We will not be discussing anaphylaxis, as Dr. Wilson gave an excellent grand rounds last year on this topic. There's a QR link to his excellent blog post on the topic. We have some admirers in the audience. I am one as well. So at the bedside, how can we differentiate ACE inhibitor angioedema from bradykinin-mediated angioedema? We have the 62-year-old in front of us with a swollen tongue. How do we know this is bradykinin-mediated angioedema beside the patients being on an ACE inhibitor? Well, other clues that clue us in to bradykinin-mediated angioedema is the absence of allergen exposure, more involvement of the tongue and upper airways, the absence of urticaria and pruritus. In addition, mast cell-mediated disorders will have more involvement of other systems, such as the cardiovascular and respiratory system, leading to hypotension, shock, and wheeze. It's important to note that GI involvement can occur in both mast cell-mediated disorders and bradykinin-mediated disorders, but by far more common in mast cell-mediated disorders. So don't get fooled by a patient with ACE inhibitor angioedema who has a little bit of nausea, vomiting, and maybe some abdominal pain. In terms of investigations, if you look through the literature, you'll see a lot of investigations that can be ordered in your angioedema workup. Unfortunately, none of them help us diagnose or even manage ACE inhibitor angioedema. There's no confirmatory test to diagnose ACE inhibitor angioedema. It's going to be all based on your excellent clinical skills. You'll read about in the literature of the potential of C4 levels, C1 esterase inhibitor levels, serum tryptase, as well as ESR and CRP. C4 levels and C1 esterase inhibitor levels are low in hereditary and acquired C1 esterase inhibitor deficiency. Serum tryptase levels are elevated in mast cell activation disorders. CRP and ESR are also elevated in C1 esterase inhibitor levels. I asked Dr. Hendon, who's an emergentologist and staff intensivist, if they rely on these tests at all in the ICU, where a lot of these patients actually end up. She said that these tests are not helpful in the ICU and they do not change her management. Tests like C1 esterase inhibitor and tryptase may be useful for the allergist who will see these patients on discharge, and she will end up ordering these tests in the ICU if there's multiple presentations with unclear trigger and no clear histaminergic cause of angioedema. Long story short, as emergency providers, we do not need to worry about these fancy tests in the emergency department. Because of the non-immunologic differential for angioedema, it is reasonable to get basic blood work in these patients, such as your CBC, basic chemistry, and renal function tests. So let's take it back to the case. We have this 62-year-old male in front of us. We suspect that he has ACE inhibitor angioedema. We talked about that this form of angioedema is a bradykinin-mediated process. Our bedside clues in this patient are the gradual onsets of symptoms, the absence of urticaria and pruritus, the absence of systemic symptoms such as hypotension, shock, and wheeze. And we said that even if this patient develops a little bit of GI upset, this may still be consistent with ACE inhibitor angioedema. No fancy blood work will help us, but we can consider basic tests such as CBC, chemistry, and renal function. In the next section of the talk, we're going to talk about the treatment. I'm going to take you through all of the proposed treatment described in the literature to treat ACE inhibitor angioedema. I will be discussing the highest level of evidence and the most recent evidence for each treatment. Treatment for ACE inhibitor angioedema has historically focused on medications used to treat hereditary angioedema or C1 esterase inhibitor deficiency and target the kinin-kallikrein system. Although we know that ACE inhibitor angioedema is a bradykinin-mediated process, we do not know the exact mechanism of this, and this makes treatment slightly challenging, which you'll see in this presentation. At the end, I will summarize my proposed algorithm based on the latest evidence. The medications that we will be discussing are the standard sort of mast cell-mediated therapy that we use in the emergency department, such as corticosteroids, antihistamines, and epinephrine. In addition, we will be discussing FFP, TXA, icatibant, ecallantide, and C1 esterase inhibitor concentrate. If some of these drugs are new to you, they were also new to me when I delved into this topic, so don't feel too bad. As we progress through the various treatment options, you will realize that the waters are quite muddy when it comes to the evidence. There's not a lot of good evidence for these treatments. The literature does agree on one thing, however. Stopping ACE inhibitors is the #1 thing that we can do at the bedside to treat ACE inhibitor angioedema. The simple act of stopping the medication will lead to resolution of symptoms in 24 to 72 hours in the majority of patients. Historically, patients presenting to the ED with ACE inhibitor angioedema were given a trial or test dose of corticosteroids, antihistamines, and epinephrine in some combination. We now have better understanding of the kinin-kallikrein system, and all the evidence shows zero benefit of these medications in ACE inhibitor angioedema. The American Academy of Emergency Medicine released a 2021 Clinical Practice Committee statement on the treatment of ACE inhibitor angioedema in the emergency department. They recommend against the use of these medications. That said, as emergentologists, I think it's reasonable to give these medications, or specifically epinephrine, if you suspect that there is a potential for a mast cell-mediated disorder. The next drug we'll discuss is FFP. So FFP works here on the kinin-kallikrein system. It contains angiotensin-converting enzyme, which is deficit in patients taking ACE inhibitors. Remember, angiotensin-converting enzyme is what breaks down bradykinin into its inactive metabolites. The standard dose is 2 units. What muddies the waters a little bit with FFP is that bags of FFP can have variable levels of angiotensin-converting enzyme, probably because the majority of patients or some of the donor patients may actually be on ACE inhibitors themselves. In addition, while it contains angiotensin-converting enzyme, it also contains all the building blocks to create bradykinin, such as kinagen and kallikrein, which theoretically could make your angioedema worse, although no study has actually demonstrated this. With FFP, there are numerous case reports that you can Google and read about in the literature of its success in treating ACE inhibitor angioedema. There's a 2013 case series that reports 7 cases that show a temporal association between the administration of FFP and improvement in symptoms of ACE inhibitor angioedema patients. The highest level evidence, though, that we have is a retrospective study done by Sabe and colleagues in 2016. This was a retrospective cohort study on all admitted patients to the ICU with angioedema in a community teaching hospital in Detroit, Michigan, between 2007 and 2012. 128 patients were included in total. They excluded any patient with suspected food allergy or hereditary angioedema as the culprit. The study had found that patients patients not treated with FFP had ACE inhibitor use of approximately 85% compared to patients who were treated with FFP had 90% ACE inhibitor use. They found that patients treated with FFP had lower rates of intubation and shorter ICU stays. That said, this was a very small cohort study. There was only 20 patients who actually received FFP. And there's a possibility that patients who were treated with FFP weren't actually as sick as their non-FFP treated counterparts. And they may have been given FFP as a way to sort of stave off the intubation that the patient may actually never would have needed. There also has been some contradictory evidence published in recent years in the form of negative case reports for FFP in treating ACE inhibitor angioedema. A case published in 2017 reports a patient who had ACE inhibitor angioedema who got worse 2 hours after administration of FFP. This potentially signals that the previous unanimously positive case reports on the use of FFP in treating ACE inhibitor angioedema may be the result of reporting bias. To summarize the evidence on FFP, there are a lot of case reports and a small retrospective cohort study, but we're not sure if FFP truly works. So what about the miracle drug that is TXA in the management of ACE inhibitor angioedema? It works here on the kin-and-killicrine system by blocking the conversion of plasminogen to plasmin, leading to decreased activation of factor 12A, which is the building blocks of bradykinin production. The typical dose of TXA is 1 gram. Similar to FFP, there are numerous case reports on the effective use of TXA in treating ACE inhibitor angioedema. There are 2 main studies that offer the highest level of evidence. The first study was a 2018 study done by Béchance and colleagues. This was a retrospective analysis of medical files of patients who had consults between 2010 and 2016 in 2 French tertiary hospitals for ACE inhibitor angioedema. There was 33 patients with severe ACE inhibitor angioedema, all received first-line treatment with TXA. 27 patients improved with TXA alone. 6 did not fully respond to TXA and received alternate therapy to which they supposedly responded to. There were no intubations reported, no deaths, and importantly, no side effects were recorded. The second study was done by Hasera and colleagues in 2021. This was a single-site retrospective cohort study done in Lakeland, United States. It included 16 patients treated with TXA for suspected ACE inhibitor angioedema from January 2019 to March 2021. The primary outcome was the proportion of patients who required intubation. 4 patients also received FFP at the same time they received TXA. The mean time for administration to resolution of symptoms was 100 minutes. 2 patients were intubated prior to the administration of TXA. The remaining 14 patients did not require intubation, and there were no adverse effects. So what's the verdict on TXA? While there are no randomized controlled trials, the best evidence does show some signal of potential benefit in terms of symptom improvement, decreasing the need for intubation, and importantly, no evidence of harm. I think there's stronger evidence for TXA than FFP. We'll now discuss the drug icatibant in the management of ACE inhibitor angioedema. So icatibant works here on the kin-and-killicrine system. It's a synthetic drug that works as a competitive antagonist to the bradykinin B2 receptor. The initial randomized controlled trials that were done in 2015 regarding the use of icatibant in ACE inhibitor angioedema did show quite promising results. There were some even reports that it prevented intubation in some patients. That said, 2 larger trials done in 2017 showed negative results. The first study was done by Straka and colleagues. This was a single-center, double-blinded, placebo-controlled study protocol that involved 33 patients, 13 patients in the icatibant group and 18 in the placebo. They found no statistical difference in time to resolution of symptoms. A second larger study done by Sinert and colleagues was a multi-center, double-blinded RCT, which included some Canadian sites. 121 patients underwent randomization, 60 to the icatibant group and 58 to the placebo. They also found no difference in the 2 treatment groups in the primary efficacy endpoint of time to meeting discharge criteria. No statistical difference in the time to symptom resolution was found either. In Canada, Kai and colleagues in 2020 performed a retrospective review of the Winnipeg Regional Health Authority's angioedema patients who were dispensed icatibant in hospital. A total of 21 patients were included. Half of them received it for ACE inhibitor angioedema specifically. They found no benefit for icatibant use in the treatment of ACE inhibitor angioedema. To summarize, there is strong evidence against the use of icatibant in ACE inhibitor angioedema, suggesting that ACE inhibitor angioedema is more than just a simple excess of bradykinin. Ecallantide is another proposed medication that has been theorized to treat ACE inhibitor angioedema. It works here on the kin-and-killicrine system. It inhibits the conversion of high molecular weight kinogen to bradykinin by inhibiting plasma killicrine. Similar to the other drugs that we discussed, case reports showed very promising results. There are 2 main studies that investigated the effectiveness of ecallantide in ACE inhibitor angioedema. The first study was done by Bernstein and colleagues in 2015. This was a phase 2 triple-blinded RCT with a primary efficacy endpoint of achieving discharge criteria from the ED within 4 hours after initiating study-related treatment. There was a total of 50 patients enrolled, 24 to the placebo and 26 to the encalantide group. 21% of the placebo group versus 31% of the encalantide group met discharge criteria from the ED at 4 hours after study administration. This was a difference of 10%. As you can see on the screen, the confidence intervals cross zero, so signaling potentially a result or maybe no result at all. The second study was a larger study done in 2015. This was a multi-center, double-blinded RCT. The primary endpoint was defined as meeting discharge eligibility criteria within 6 hours after study drug administration. There was a total of 79 patients randomized, 18 to the placebo and 58 to the encalantide group. This trial was stopped early as interim analysis revealed a higher than anticipated response rate in the placebo group. Because of this, the study was determined to be inadequately powered to detect a statistically significant difference between the two groups, and the trial was stopped early. No statistical difference in discharge eligibility was found. So there's pretty solid RCT evidence that we should not be using encalantide in treating ACE inhibitor angioedema patients in the emergency department. The final drug that we'll discuss is C1 esterase inhibitor concentrate. An example of this in Canada is known as Berinert, which will be prescribed to most of our hereditary angioedema patients. C1 esterase inhibitor concentrate acts here on the kinin-kallikrein system. It acts by increasing C1 esterase inhibitor, which is, again, the regulatory protein of the kinin-kinogen system. There have been numerous case reports about its successful use in ACE inhibitor angioedema. And in 2015, Grave and colleagues did a proof of concept case series with historical control of ACE inhibitor angioedema patients. 10 patients were included in the patients treated with C1 esterase inhibitor and 47 in the patients treated with corticosteroid antihistamine. Time to complete resolution of symptoms was considerably longer in patients treated with just steroid and antihistamine and no C1 esterase inhibitor. There were no intubations and no tracheostomies reported in the C1 esterase inhibitor group, and 5 intubations and 3 tracheostomies in the patients not treated with C1 esterase inhibitor. This signaled potentially some benefit of this drug in treating ACE inhibitor angioedema. However, a recent 2021 retrospective propensity match cohort study done by Mahorn and colleagues compared patients who had received C1 esterase inhibitor for ACE inhibitor angioedema compared to those who did not. There was 82 patients included, 57 patients in the non-C1 esterase inhibitor group, and 25 patients in the C1 esterase inhibitor group. After propensity matching, 22 patients were included in the C1 esterase inhibitor group and 22 in the non-C1 esterase inhibitor group. They found no difference in proportions of intubation and substantially higher costs. So just take a look at that number down below. So they found that patients treated with C1 esterase inhibitor group, their drug costs were average of $8,000 compared to $15 in the non-C1 esterase inhibitor group. I don't think there's enough evidence here to be using this drug in the treatment of ACE inhibitor angioedema in the emergency department, given that this study has demonstrated that there's no difference in proportion of intubation and it costs the system a whole ton of money. All right, so if I've lost you or you're starting to fall asleep, just take a second to wake up because this is the money slide. This is a summary of the highest and most recent evidence of ACE inhibitor angioedema treatments in the emergency department by drug. So let's jump into it. There is no evidence for the use of corticosteroids to treat ACE inhibitor angioedema in the emergency department. For FFP, although there is some case reports that show benefit, there are newer case reports that are being published that show some signal towards harm. And despite the cohort study that I discussed, there's also a theoretical risk that you might make your angioedema worse because it contains all the substrates needed for bradykinin production. In addition, the standard dose of FFP is 2 units. So 2 units of blood products is a lot of volume to be giving to patients with CHF and CKD who are disproportionately on ACE inhibitors. So I don't think there's enough evidence there, and given the new potential signals for harm, I don't think we should be giving these medications to our ACE inhibitor angioedema patients. For TXA, there's slightly better evidence with multiple case reports and 2 retrospective studies showing some signal towards decreasing the need for intubation, increasing the speed for resolution of symptoms, and the absence of harm. So I've given it the green light here. In addition, it's also the cheapest medication that we can give for ACE inhibitor angioedema. I will let you know that the AAEM guideline does not recommend using this medication in the treatment of ACE inhibitor angioedema. That said, they actually don't cite any papers in their literature. They just say that there's not enough evidence. For icatibant and encalantide, there's quite large RCT level evidence that we should not be using these medications to treat ACE inhibitor angioedema. For C1 inhibitor esterase concentrate, there is no RCTs, but I think that recent retrospective propensity match cohort study that I cited from Mahorn and colleagues done in 2021 does show that there's no evidence to suggest that it helps with decreasing the need for intubation and is associated with substantially higher cost. So I don't think we can justify its use in the emergency department. Remember that the single best thing that we can do for our patient at the bedside is the discontinuation of the ACE inhibitor. In the final part of the talk, we'll address airway management in ACE inhibitor angioedema. This is probably the most important part of the talk. We can think about intubations in 2 steps. The first step is the assessment, and the second step is the intubation. So who will need intubation, and what can we use to predict who will need an intubation? Mutta and colleagues in 2020 did a retrospective study of 183 patients presenting to the emergency department with ACE inhibitor angioedema. They found that 9.5% of patients needed intubation. Those patients who needed intubation were more likely to have rapid progression of symptoms within the first 6 hours, anterior tongue swelling, vocal changes, drooling, and dyspnea. Patients less likely to need airway management were more likely to have simple isolated lip swelling. Other things from the literature that can predict the need for intubation are patients who can't swallow, have inspiratory stridor, or cyanosis. In addition to the factors used to predict the need for intubation, the nasopharyngeal look is a second piece that is essential to our airway assessment in ACE inhibitor angioedema patients. The AAEM recommends this as first line in airway assessment in patients who do not need immediate airway intervention. A recent retrospective study by Guyon and colleagues in 2022 supports this. They found that the nasopharyngeal look was normal in angioedema patients who did not require intubation. Locally, you should be using the NP scope to do this. However, we do have a new portable flex scope that's attached to our glide scope that you can use inserted through the nose if you're in a bind. When using the NP scope, what are we looking for? We're looking for laryngeal edema or posterior pharynx involvement. In the retrospective study, Chan and colleagues found in 2014 that 65% of patients with laryngeal edema needed airway intervention. If laryngeal and pharyngeal are both present together, you should be intervening on the patient's airway. So what does that look like? If you've never done a nasopharyngeal scope to assess an airway before, here's a picture that you should be familiar with that is the normal anatomy when doing video laryngoscopy to look at the vocal cords. You see the epiglottis at the top of your screen and the posterior cartilages on the bottom of the screen. You sort of see an upside down V made by the vocal cords. Using a nasopharyngeal scope, the image is simply upside down. So you'll have the posterior cartilages at the top of your screen, the epiglottis at the bottom of your screen, and the vocal cords will make a right side up V. This is an example of an ACE inhibitor angioedema patient who has some laryngeal swelling. So again, you see the epiglottis at the bottom of your screen, the posterior cartilages at the top of the screen, and you can sort of see the vocal cords poking through, making that right side up V. This is an example of what spectrum of abnormal anatomy will look like on your nasopharyngeal look from mild to severe. So on the right hand of the screen, you see sort of very mild laryngeal swelling, and then sort of 25%, and then towards the left, you see almost 100% swelling of the larynx. So we talked about assessment. We'll now talk about the final step, the tube or the intubation. Across the country, there is a large amount of practice variation in intubating ACE inhibitor angioedema patients. My goal over the next couple slides is to try and convince you that awake nasopharyngeal intubation should be the standard of care when we try to do airway management for these patients. There was a retrospective Canadian study done by Driver and colleagues in 2017 of patients presenting to the emergency department with angioedema. The majority were ACE-induced. They reviewed videos for each intubation in 45 patients. They found that the median time to intubation was 33 minutes. The majority of patients, 73% of patients, were intubated through nasotracheal intubation, and the second most common method of intubation was video laryngoscopy. Providers who used video laryngoscopy had higher success rates if this was used as a primary method of intubation as opposed to a rescue. Importantly, they found that rescue LMAs were used successfully in the 5 cases where there was multiple failed attempts at intubation. Providers were able to oxygenate and ventilate successfully until a secondary airway could be established through a rescue LMA. In terms of first-pass success, you can see that the greatest first-pass success and lowest rates of esophageal intubation occurred when some sort of video was used. Interestingly, during video laryngoscopy, in 3 cases, the bougie was used despite the operator's inability to recognize laryngeal anatomy, and this resulted in successful intubation. So why are we harping on this so much? Why can't we just intubate these patients like we normally do with our standard RSI and video laryngoscopy? Here's an example of what a potential ACE inhibitor angioedema patient may look like. I want you to imagine what would have happened if you used your standard sort of RSI intubation with a paralytic that you do with the majority of patients you see in the emergency department. You can see the provider tries to engage the vallecula. They see a significant amount of epiglottic swelling. They then try to back out and in good airway technique, try to lift the epiglottis up. And you can see that it's quite hard to identify the structures. They sort of see bubbles, and that's where they're going to try to put the tube. These are patients that we should not want to rush to paralyze if we can help it. The provider then uses a bougie and then passes it through and finally gets the airway. This is why it's important for us to discuss how we're going to obtain good control of these airways in a safe and effective manner. This past month, I had the opportunity to do the AIM difficult airway elective in Halifax, as well as take part in the AIM course. I was able to discuss airway management of ACE inhibitor angioedema patients with Dr. Parks, one of my mentors, and an AIM instructor and former Ottawa emergency medicine alumni. His main initial thoughts were that although dynamic, remember that these patients always have time. As you can see from the driver study, even the patients that needed intubation, there was about 33 minutes before the patient actually got the tube. So we often have more time than we think. Acknowledge that the likely safest place for these patients is to be intubated in the OR with ENT present to perform an awake trach if necessary. That said, we do recognize that there are center and consultant availability issues or rapidly progressive pathology that may need intubation in the emergency department. In these cases, our primary first line should be an awake nasotracheal intubation. Do not rush to give these patients a paralytic and do an RSI because it can kill them. It should be done by a provider comfortable with the procedure, as manipulation of the airway can actually lead to the further release of factor 12A, leading to worsening angioedema. We don't have time to go through how to do a nasal awake intubation. Dr. Nick Choi gave an excellent grand rounds last week on how to do an awake intubation. If you want to learn how to do a nasotracheal intubation specifically, it's not much harder. It's just an extra step of putting a tube through the nose. There's a QR link to the AIM chapter on that topic that will take you through a bunch of videos, a bunch of resources on how to safely do it. I promise it's not that hard. In terms of preparation, Dr. Parks agrees that the NP scope should be a standard part of our airway assessment in all these patients. He also advocates for marking the neck in all these patients. Number one, it becomes habit and earns us extra practice of identifying emergent front of neck access anatomy. In addition, the most recent Difficult Airway Society guidelines suggest that if you can't confidently identify anterior neck structures because of neck edema or swelling or the patient's very obese, your initial vertical incision should actually be quite a large one. 8 to 10 centimeters to help you identify anatomy during blunt dissection. After discussing ACE inhibitor angioedema airway management with Dr. Parks, here's my approach that I would recommend that we should take. The first step is deciding whether or not your patient is maintaining their own airway and ventilation, and whether or not you think they can tolerate an awake nasotracheal intubation. If they can tolerate an awake nasotracheal intubation, you should do a double setup with the neck prepped and marked, and consider even injecting local anesthetic with lidocaine with epi to the anterior neck skin. You should have all of your exit strategies at the bedside. So as Dr. Nick Choi talked about last week, you need to have all of your RSI drugs at the bedside. You have to have your bag mask ventilation ready to go, your VL, and your supraglottic airway. You're then going to do a awake nasotracheal intubation with a 7.0 ET tube or smaller. Remember that you're dealing with quite tight anatomy, so you cannot be reaching for your standard 7.5 or 8 tubes. They will not fit through that tight space. If reaching for something that is smaller than a 7.0 tube, ensure that you recognize that a standard ET2 tube will be too short to reach the glottic inlet, especially in taller patients. So if you're reaching for a 6.0 tube, you need to grab a nasal 6.0 because a regular ET tube that's a 6.0 won't reach the glottic inlet. It will be too short. If a patient cannot tolerate awake intubation or they're not maintaining their airway and ventilation, you're going to proceed with an RSI crash intubation. Even though we call it a crash intubation, remember that you do have some time, okay? You're going to want to try to optimize your oxygenation as much as possible. In Halifax, they teach 2 hands and 2 sources of oxygen as your primary way of oxygenating these patients. That typically involves nasal cannula with high flow nasal prongs, in addition to a bag mask with a PEEP valve mounted on it. You're not bagging the patient, you're just putting the PEEP on to apply high pressure oxygen to the system to try to get your oxygen reserves increased as much as possible. You can also consider BiPAP if you have access to it to try to help facilitate improved oxygenation of these patients. You're then going to perform an RSI with triple setup. So a triple setup is sort of a new term that we're hearing. It involves having a flex scope, a VL, and emergent front of neck access, all prepped and ready to go at the bedside. You're going to make your first attempt. You're going to start by inserting your video laryngoscope into the mouth, used to lift the tongue out of the way. You're then going to use a nasal flexible scope with a 7.0 ET tube mounted to it, and you're going to use you're going to have 2 screens set up, and you're going to use your nasal flexible scope in addition to your VL to sort of guide your flexible scope into the glottic inlet. Once you're into the glottic inlet, you're just going to look at your flexible scope screen, and then you're going to perform the intubation. If you're not successful with that, you're going to take everything out, and you're going to put an eye gel in, an intubating eye gel. This is going to be what you're going to use to reoxygenate the patient. There's quite good evidence from that driver study that I quoted earlier that this will get you out of a bind if you need it. You're then going to take a 6.0 tube mounted on your flexible scope and try to go through the eye gel. Remember the number 6.0 because this is the only size tube, 6.0 or smaller, that will fit through the eye gel. A 7.0 will not fit through the eye gel. So it's important to change over to a 6.0 tube and try to intubate through your intubating eye gel. If at any point you have refractory desaturation or you're unsuccessful after step 6, don't sweat. You always have emergent front of neck access as your backup, and you've already had that at the bedside, prepped and ready to go. Here's an example of what a failed first pass intubation may look like. Here, the provider has inserted an eye gel. Maybe this will work. All right, so the provider has inserted the eye gel, and you can see that they take the flexible scope, they insert it through the eye gel. They're then gonna stop, take a look. They're gonna see the glottic inlet, the vocal cords. They're gonna pull back, you don't necessarily have to do this, but they pull back a little bit just to get around the corner. And then they just insert it straight through the vocal cords, down, and then once they see carina, they're gonna pass that 6.0 tube that they have mounted on the flex scope through the eye gel, which passes pretty snugly, okay? There should be no issues in terms of size. And then they're gonna sort of advance out. You can take that ET tube connector piece off after and use another 6.0 tube sort of connected to it and sort of advance the eye gel over that 6.0 tube to get the eye gel out. Although that's not the priority, you have the airway secure, RT can help you out with that. So let's bring it back to the patient we met at the start of these rounds. We have a 62-year-old guy in front of us. He's got no allergy exposure, no allergens. He's only on an ACE inhibitor. We've already identified him as ACE inhibitor angioedema based on the gradual onset of symptoms, the lack of systemic involvement, the lack of urticaria and pruritus. And even if this patient had GI involvement, we would say potentially can still be ACE inhibitor angioedema. We've decided he has ACE inhibitor angioedema. What are our next steps? So this is the algorithm based on the evidence that I think we should be taking. Our focus in all of these patients needs to be on airway assessment. Forget about all the other treatments that we've learned about. Forget about TXA, everything else. Focus on airway assessment. What are we looking at our airway assessment? We're looking for obvious signs that this patient will need an immediate tube or a very urgent tube. These include cyanosis, stridor, drooling and dysphagia, or dyspnea. Remember that while doing this airway assessment, if at any point you're suspecting that there may be a component of anaphylaxis, there's many cases in the literature where a person is on an ACE inhibitor, they went out and had some shellfish, and now they have sort of airway swelling. It's always safe to give a dose of IM epinephrine while concurrently doing your airway assessment. If you recognize that the patient has airway distress, you need to do an intubation and manage their airway. Remember, you have some time and you need to try to do this as safe as possible. Depending on where you're working and depending on the daytime and what resources you have available to you, you should always, best practice is always try to get ENT and anesthesia involved early if you can, even if it's just to call them in to try to come to the bedside while you're getting everything set up and taking the airway. You should try to proceed still with an awake nasotracheal intubation. I recognize and I will identify that these patients who are crashing actively in front of you, it may be very difficult and you may not be able to do an awake nasotracheal intubation. If that's the case, you're forced to act. You have your RSI with triple setup as your step 2 or your secondary approach to the airway. And then step 3 or your third airway plan is always emergent front of neck access. Remember to mark the neck in all these patients right when they come in. If the person doesn't need immediate intervention, you should be doing a nasopharyngeal look. I know it's tedious to get the NP scope and try to find it in the CF's office, but I think that should be the standard of care based on the most recent evidence, that we should be taking a look at the back of these patients' throats to look for laryngeal and pharyngeal involvement. If you see anything more than mild laryngeal or pharyngeal involvement, you strongly need to consider taking the airway in these patients. You should, again, try to have ENT and anesthesia coming in to help you out if you can. These patients, you should really try and advocate for an awake nasotracheal intubation. Your secondary is always an RSI with triple setup, as we almost standardly would do, and emergent front of neck access. I can't stress the importance of a triple setup. The reason we're going through the nose is because the tongue is quite big, and oftentimes, even with our standard VL blades, we're not going to actually be able to see too much, as you saw in that previous video, with just a standard sort of VL. A nasopharyngeal scope will give us a much better look. After you've managed the airway, my recommendation would be to give a gram of TXA. I recognize that there isn't a lot of evidence for it, but there is some signal in the literature, very low-level evidence, that it may decrease the rates of intubation, improve time to resolution of symptoms, and importantly, there's no harm. It's also very cheap, $8. If you're working in a center that doesn't have access to a nasopharyngeal scope, or you have no flexible scope, nothing sort of available to you, other clues that you can use at the bedside to say this patient may need an urgent airway are things like rapid progression of symptoms, anterior and posterior tongue swelling, vocal changes or globus sensation, soft palate swelling, as well as lack of isolated lip swelling. In terms of disposition, there are no hard and fast rules or guidelines to predict which patients should be admitted or which patients you can send home. Your clinical gestalt will always be key. In 2016, an expert opinion article by ENT surgeon Dr. Boss, who publishes extensively on the topic of ACE inhibitor angioedema, recommended this approach. For your nasopharyngeal look, if you have more than 25 to 50% obstruction, you should be managing the airway in terms of intubation or awake trach if you have access to it. In terms of tongue swelling, if tongue edema is obstructing your view of the soft palate and uvula, in other words, your soft palate and uvula aren't fully visible, you really need to be considering managing these patients' airways. And if you're not managing these patients' airways in the emergency department, they should be 100% admitted to a monitored setting. As you can see that photo number 4 over there of the tongue, you probably should be tubing that person. There's another sort of staging system that has been described in the literature called the issue classification system. There's starting to be emerging evidence to support this. It's based on sort of severity of angioedema and where these patients should be ending up. Again, this isn't the hard and fast rule. Your clinical gestalt will be key, but it says that if you have isolated lip swelling and there's no sort of airway involvement, these patients could actually be sent home. If the person has soft palate or posterior pharynx involvement, they should be sort of admitted to a monitored unit. Similarly, if they have tongue swelling, depending on how severe it is, admitted to a monitored unit. And then if they have laryngeal involvement, it recommends that this person either needs a tube or ICU, but in most cases will need an intubation. So if you're wondering what the purpose of the snake in the first slide was, for those of us studying for the exam, you guys will all know that this is a pit viper and contains some venom. Interestingly, this is a South American pit viper whose venom was found to cause hypotension after people were bit with it. The cause of this hypotension after much research was found to be a peptide in the venom that contains an angiotensin converting enzyme inhibitor, and this peptide actually formed the basis of ACE inhibitors that we know it today. So with that, I just wanted to say a quick thank you to all the people who've helped me and supported me throughout the way. Shout out to Dr. Alicia Damo, my partner, for all her love and support. She's also listened to this grand rounds countless times, and it was all her editing that made the slides look as good as they did. I don't have that touch, so thank you. I appreciate all that you do for me and continue to do for me. I'd also like to thank my supervisor, Dr. Christian Yadav, who has been an outstanding mentor and support in this program and for supervising me with this grand rounds. He gave me excellent feedback on the topic and was kind enough to sort of listen to me go through it a couple times, so I really appreciate that. Also, my mentor, Dr. Adam Parks, who assisted me and was essential to the building of this Airway talk. I think he might be online as well. I'd also like to give a special shout out to our expert advisors, Dr. Errol Hendon, as well as Sabrina Natarajan. I'd also like to thank my R4 cohort and my MOCDD crew. You guys know who you are. I could not survive this residency program without you, so thank you. With that, I'll open up the floor to questions, and if you want to take a look at my work and my references, there's a QR link up top. Hey.
Great talk. That's really helpful. I have some questions around timeline. Get a sense of at what point after their last dose ACE inhibitor, like when versus their symptoms, they're going to do that help guide our intubation or our discharge planning.
So Dr. Kareem Hashim had a great question about sort of like timing of when they took their ACE inhibitor in terms of can it help you to sort of determine when you need to sort of intervene on their airway or manage their airway. There's no sort of guidelines on that. We know that ACE inhibitors, regardless of when you take it, can happen sort of randomly. Just the fact that a person's on an ACE inhibitor means that they can develop angiotensin converting enzyme sort of related angioedema. So there's no sort of timeline that we can use in terms of like looking at the half-lives of these medications to determine whether or not a person will need an intubation. It's all sort of random in terms of when a person will get the angioedema, how rapidly it'll progress, and sort of how quickly it will resolve. Some people, honestly, even though we sort of discussed TXA and sort of its improvement in sort of symptom resolution, it might all just be that those people are quicker responders and we gave the TXA and now they responded. So there's no clear guidelines. You have to do it sort of on a case-by-case basis to determine how rapidly you need to intervene depending on their progression of symptoms and how sick they look in front of you. Dr. O'Connell. Parks, do you have anything you want to add? I'm going to put you on the spot. not all good. All right, if there's no other questions or comments, thank you very much. Appreciate it.
Sorry, Nick, I'm gonna ask another
Yeah.
question. Did you find, I know you're focusing on edema for other types of acquired or hereditary angioedema, are you still going to use TXA, FFP?
So for it depends. So if the person has acquired C1 esterase inhibitor deficiency and you can prove it somehow based off of blood work, but C1 esterase inhibitor levels takes weeks. Like this in Ottawa, our blood work gets sent to Toronto and it takes like 4 weeks to come back. So it's very rare that you have it. But if you have it, there's actually strong evidence that we should be using C1 esterase inhibitor for it. Recognizing that the cost, like just to sort of bring up this slide, the cost of these medications are not cheap. Like it's $2,000 per dose. So in the emergency department, I think our focus really needs to be on just airway management. TXA, like there's no harm to giving it. In sort of the literature that I reviewed, even in terms of like DVT at 28 days, there's been sort of no reported harm. Like we give it to people who look as us funny in the trauma bay. So it's, you know, I don't think there's any, like I would personally give it if I have angioedema that I'm sort of not sure. But there's no sort of hard and fast rules. Like if it's unexplained sort of angioedema, you sort of can do whatever you want. I mean, some people will give FFP, some people will give TXA, but I really do think the only med, if we're going to give anything at all, should be TXA. Yeah, exactly. Yeah. Okay, thanks.